Okay, are you able to see that?
Yes, sir.
So, suspected stroke algorithm. So, test stroke probability, instruct the patient to show their teeth or smile, evaluate facial droop, next evaluate arm drift. So, if ask the patient to close their eyes and extend both arms straight out with the palm up for 10 seconds. If they are not able to do that, that's called arm drift. So if abnormal, one arm does not move or one arm drifts down compared to the other. This is the classical way of it is happening. And then evaluate for abnormal speech. So patients say you can teach an old dog new trick. Of course, that's not possible in our population. So you will form your own method of finding out. And there is usually a slurring or use of wrong words or unable to speak. These are the three abnormalities in speech that will happen. Patients' speech will be slurred, or they may use the wrong words, or they are not totally able to speak at all. So these are the three things that. So if any one of the three signs is abnormal, the probability of stroke is 72%. So this is the basic thing that we have to first evaluate. Or anybody who is in the family should also, now there is a lot of public awareness program is going on to teach everyone in the family, especially elderly people, non-hypertensive, they can suddenly develop this problem at odd hours. So the family members themselves should be able to do this test and evaluate whether it is a possibility of stroke is there or not. So the face, one side of the face is drooping, arms, the arm is weak and not able to lift. Speech is quality is difficult or slur words or not able to speak. And lastly, the time to call the ambulance is very, very important. So this acronym FAST is now used by all stroke treating hospitals as a very important thing, which should just like the codes, which is being popularized for basic life support. Compression only life support is now being popularized among the public so that patient's life can be saved. Similarly, time is very, very important in stroke management. From the time the patient is suspected or recognized to have a stroke, that whole treatment should be done within 3 hours. And the shifting of the patient and reaching the hospital should be within 20 minutes. That is the criteria that they are now trying so that the maximum advantage will happen to the patient and he can completely recover from stroke. Earlier days, the neuro people used to just wait for the patient's own recovery. But nowadays, a lot of interventions are possible and patient can be made to regain the lost neurological actions very fast. Otherwise, it will take a long time for the patient to regain their normal function. So there is added now is another thing what is called two more things have been added to the earlier fast acronym that is called the B fast acronym. The B stands for balancing. Sometimes patients find it not able to balance themselves. They have a giddiness and eye signs are blurring or rotating eyes also is now included into the facial, arm and speech problems. And again, the time is given more important. So the uh, latest version of acronym is Be Fast rather than just fast. And there is also what is called the faster. That is facial problems like drooping or arm drifting, speech problem is there, talking problem is there, eye problem. And instead of time, they have put react. So just don't say time is important, but react faster. So the FASTER acronym is also used for stroke identification and early treatment organization. So the pre-hospital intervention by the emergency medical service will focus on supporting the ABCs and giving oxygen if indicated, performing what is called the pre-hospital stroke assessment. Now checking glucose, establishing time of symptoms, that is until when the patient was normal, that is called the time of symptom onset or the last normal seen patient, and triaging a stroke center and uh, alerting the hospital to activate the stroke team. These are the 4 things that have to be done. They are given importance to checking glucose because hypoglycemia many times may mimic a stroke, but it is an easily reversible condition by just pushing some glucose into the body. So checking the glucose is vital whenever a patient is being transported with the suspicion of stroke. Then comes the establishment of the time, because as I said earlier, now stroke management is time oriented or based on the time that is identified and the treatment started. So the time of onset is very important, and then triaging in the stroke center and alerting the hospital to activate the stroke team. Within 10 minutes of emergency department arrival, you must perform an immediate general assessment and stabilize ABCs if necessary and provide oxygen therapy if it is not being done during the transportation. Obtain IV access and perform laboratory assessments. Check glucose if it is not done already and again treat it if indicated. Obtain a 12-lead ECG and perform neurological screening assessment. Do not delay CT, and as early as possible obtain a CT without contrast within 20 minutes of patient arrival to the emergency department or the stroke unit, whichever may be the place. So 3 things: check glucose, take ECG, and then do a CT. These are the 3 things that have to be done as quickly as possible: glucose estimation, ECG, CT scan. And sometimes, many times, CT scan may give you a clue about the location and what is the actual pathology. A neurological assessment by stroke team or a designee should be done within 20 minutes of patient arrival in the ED, and review patient history, establish the time of symptoms onset or last known normal, and perform examination using a standardized tool or a NIH stroke scan or Canadian neurological scale. If the CT scan shows hemorrhage, consult a neurologist or a neurosurgeon and consider transferring the patient to a neurosurgical unit rather than the neuromedical unit. Begin stroke or hemorrhage pathway for that. Admit to a stroke unit or intensive care unit. If CT scan shows no hemorrhage, consider it is as a ischemic stroke with a clot, so fibrinolytic therapy is indicated. This treatment has revolutionized the result of any patient suffering from stroke with the early recovery. So check the fibrinolytic exclusions, repeat the neurological exam to determine if symptoms are improving or worsening. Candidates with the onset of symptoms within 3 hours or 4.5 hours in selected patients are eligible for fibrinolytic therapy. So the golden time for fibrinolytic therapy is less than 3 hours should be done. But in some cases, exceptionally, you can wait up to 4.5 hours or 4.5 hours. If the patient is a candidate for recombinant tissue plasminogen activator, review the risk and benefits of the patient and the family. So you should not blindly start this in all the patients. So if there is a risk of any major bleeding elsewhere, then you have to think about that. And begin fibrinolytic therapy within 60 minutes of patient arrival to the emergency department. Consider endovascular therapy for the onset of symptoms up to 24 hours for large vessel occlusion. Admit the patient to a stroke care within 3 hours of arrival to the emergency department, and begin post RTPA stroke care. Monitor blood pressure and neurologic symptoms. Monitor for adverse reactions to fibrinolytic therapy. And the stroke chain of survival. This is a very important point. If you remember this, you can write the answers what I written earlier. The stroke chain of survival for management of acute stroke comprises of 8 steps, which are called the 8 Ds. The first D is detection. Second D is dispatch. Third D is delivery. Fourth is door. 5 data. 6 decision. 7 drug and device. And 8 is disposition. Now we will see what does each one mean. So first thing is detection. So early detection and recognition of stroke symptoms speed the implementation of appropriate medical intervention and improves patient outcome. That is why all this acronym like FAST, be fast, faster, all these things have been made popular among the public with lot of codings, handbills and other things, so that even non-medical or lay people should be able to identify whether a patient is suffering a stroke or not. So early detection is very, 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 very important. The second thing is dispatch. Dispatch the patient from the site of recognition or detection to the concerned hospital. That is what is called the dispatch. Now, supposing you identify a patient to or suspect a patient to have a stroke at home, would you prefer to transport him in your own car or in your own conveyance, or would you like to call the stroke hospital for an ambulance and ask them to come and pick up the patient? Which is better? Are you all there?
We can shift in car, some other vehicle, sir.
What's your answer?
Stroke ambulances are available.
அதான் இப்போ both stroke ambulance is available and your car is also available. Which one is better?
Stroke ambulance is better.
Yeah, you can always depend on stroke ambulance, provided it can come very soon to your house. Okay?
Right.
Because what is the advantage of calling for a stroke ambulance?
Radiological.
It comes with the doctor. They can check the blood glucose at home. They can evaluate the patient. They can intubate the stroke and then team and get ready. And by the time patient reaches the hospital, everything will be ready and time delay will not be there. Whereas if you take the patient in your own conveyance, your car, then you have to go tell the emergency, you go to the common emergency department, not a stroke emergency department. Then everyone has to see and then activate the whole team. So there's a lot of delay will be there. So it is always preferable to call the ambulance so that you can avoid the time delay. So dispatch involves early activation of emergency medical services. This helps the ED to be ready to receive the patient and having the proper providers and systems ready for treatment. The third thing is delivery. Delivery means delivery of the patient to the stroke center. So instead of going to just common hospital, if you are aware of any particular stroke center, nowadays most of the hospitals display where they have a 24-hour stroke service or not. So choose a place like that and better to take the patient and deliver them at that particular hospital. Then what is called the door, arrival at the emergency department of the stroke center is called the door. That is the fourth. Door refers to the arrival of the patient at the emergency department. Now 5, data. Data means whatever the investigations you do and what are the results. A non-contrast CT scan should be performed to differentiate between ischemic stroke and hemorrhagic stroke. Then the decision. Decision is whether to start fibrinolytic therapy, what type of treatment to be done, whether to refer to the surgical unit or you can start a treatment. That is the decision making. Drug or device. If the drug administration is appropriate, is the next link in the chain of survival, or whether you can go for interventional therapy. That is the 7th drug or device. Disposition. This step in stroke care focuses on the continuing care of the stroke patient. So if you remember these 8 points, most of your answer will be covered. So this is how you can just easily remember these things and this is called the algorithm of acute stroke management. This is the latest guideline according to 2020 guidelines. So that should give you a fairly good idea of what to write for this particular question.
Thank you.